Hi, everybody. Welcome to episode 3 of OCD and. Today, I'm joined by Dr. Marino from Sheppard Pratt. We're going to talk about OCD and geriatric psychiatry. Dr. Marino, thank you so much for joining me.
Oh, it's my pleasure. Thank you.
So first, just get us started with a little bit about yourself and what you do at Sheppard Pratt.
I'm a geriatric psychiatrist. I'm the medical director for geriatric psychiatry here at Sheppard Pratt.
So I think a lot of reviewers might not be familiar with what that really even means. I mean, how do you define what is geriatric and what is it about geriatric psychiatry that's different from other forms of psychiatry?
Well, geriatric psychiatry is a specialty within psychiatry that focuses on the mental health needs of people over some arbitrary age. We don't really have good biomarkers for age, so we measure it chronologically still in medicine. So we, and different geriatric psychiatrists will bend the definitions, but certainly a common marker would be the age of 65. So geriatric psychiatrists treat all psychiatric problems over the age of 65, as well as illnesses that are associated with aging, such as dementia. There are a number of early onset dementia syndromes that occur well before the age of 65. So those patients often go to a geriatric psychiatrist as well.
It's interesting how we talk about medical illnesses and psychological illnesses, and a medical illness, something that happens particularly in older people that affects the brain. We then send them to a geriatric psychiatrist. It's a medical illness, and it doesn't affect the brain. We call it medical. If it does, we call it psychiatric. It's just interesting how we try to, sometimes these things seem separate, but really they're not separate. If it's impacting the brain, it's psychiatry.
That's very true. And what we find as geriatric psychiatrists is that we often end up focusing on the behaviors and symptoms that the person is most suffering from. There are illnesses where we have very little ability to alter the course of the illness, such as Alzheimer's disease or vascular dementia, et cetera. But we can make huge differences in quality of life and alleviate the suffering associated with specific symptoms. So we often, while we always search for the correct diagnosis, which will guide our treatment, we always are focusing also on the problematic behaviors and the sources of the stress for the patients, because for us, it's about quality of life.
So if you have something that's happened to the brain simply because of aging, or something that's sort of maybe had a genetic timeline to it that's now been revealed, and it impacts this person's behavior or the way they relate to their thoughts and feelings. So they're developing what a psychological or psychiatric problem as a result of an organic change in the brain. You're really trying to address both issues, right? The cause but you're also teaching people how to adjust to this new relationship with their thoughts and feelings that's being caused by this change in the brain.
Yeah, I think that's a interesting way of putting it. We help people accept the limitations, if there are new limitations that have come along with their illness. We help them to cope, and we also help them to overcome the reversible behavioral issues where they arise.
Let me ask you a very granular question from an OCD focus. I'm wondering if somebody has OCD their whole life and it never goes treated, and then they develop something like Alzheimer's that might impact certain areas of their cognitive functioning. I guess the part of the brain that's impacted by Alzheimer's isn't necessarily the same part of the brain where we see OCD. So we wouldn't always, it's possible that we wouldn't see any change in the OCD with the addition of Alzheimer's. Does that question make sense?
It does make sense. I think it's important to note that when people say Alzheimer's disease, they have different images that come up in their mind. They may be thinking of somebody early in the course who's beginning to have some memory problems and is distressed and anxious about that. People in the middle stages who become unaware of their cognitive deficits and become very paranoid about other people stealing their keys or whatnot. And then the later stages, which are characterized by apathy. There isn't anything that I know of to sort of say whether the person's OCD is going to get better or worse with the onset of Alzheimer's disease. There's nothing about Alzheimer's disease that would cause previous symptoms to get better or worse. If there are issues that I think one of the things that alters the course of OCD and the treatment of OCD in patients with Alzheimer's disease is their ability to participate in the treatment.
Right.
So if we're looking at the outcomes of treatment, there's a big difference because some of the most effective treatments of OCD rely on the patient's ability to follow complex instructions and to do complex analysis of their own thought process and to utilize that.
When you encounter somebody, for the first time, who's over that magic number 65, and they're looking for geriatric psychiatry, and you discover that they have OCD, is there anything that you do differently in terms of medication or the treatment approach that you would suggest, provided that they didn't have the difficulty with the cognitive functioning otherwise? Is there anything you would do differently if you were to meet a patient who was under 65?
No, I would say no. Not as the age difference doesn't really mandate a change in the treatment approach. On the other hand, the treatment approach is really a combination of interventions that are tailored to the individual. So that core aspect of the treatment of OCD in my practice doesn't really change according to age. Again, age is sort of a random marker and a crude marker, and we use it as a crude division line. But there are certainly older people who are functioning at a very young biological age, and there's younger, chronologically younger people who are functioning at a sort of biological older age.
Yeah, it's interesting how we have all of these ideas about people at different ages. We have all these categories that we put people in, and one of them is older person, and we're expected to think about them completely differently from somebody who's younger, when in fact in many ways, like you're just describing, that that's not really the difference. The difference is that individual and their individual needs, not necessarily their age.
Yes, and you're capturing a very broad range of ages here. We've got people who are by the arbitrary limit of 65 going up to well into the hundreds and 114 or something.
Wow.
There's there's 50 years of difference between the youngest and oldest patients. Many of my patients could be the parents or even grandparents of my youngest geriatric patients.
Wow, that's amazing. I found in some of my work with older clients in their 60s or 70s who have not had a lot of OCD treatment previously, that because they've been living that way for so long, and only now are they really frustrated by the impairments that come from it, maybe because there's been a change in their family system or something like that that's really brought these symptoms to the forefront, that there's sometimes some resistance to learning psychological flexibility. I've always been this way. How can you ask me to change? There is a different dynamic than when I'm working with a young person, for example. And I wonder if there's any truth to that beyond the psychological. If someone's been behaving the same way for 60 or 70 years, is their ability to learn new things and respond differently to their thoughts, is it just more difficult because of how long it's been that way? Is there a neurological reason to think that that's the case, or is that just what we tell ourselves?
Well, one thing that I can't answer that definitively, but one thing we do know is that we form pathways and our brain reinforces pathways, and something that has been chronically reinforced, it's like it's like a dirt road that's been sort of newly cut from the woods, or one that has been tread upon for a couple of decades. Once these pathways are established, they become reinforced and entrenched with chronic use. And there's intuitively there's reason to believe that it would be harder to treat. And again, when you think about younger people, you're also factoring in the idea that it has a newer onset, right? So the
Right.
people who are previously high functioning, who develop disabling symptoms, feel as if they're gonna need to get rid of those symptoms in order to get back to normal. But once the symptoms become part of the normal, and the person has been adequately successful, because they must have been, because they didn't seek any treatment. I would say must be, but probably are.
Or they were able to hide their symptoms, so there weren't so many
Right.
social
So they've
repercussions.
been adequately functioning from their own point of view for a period of time. There's no way to know that you're actually gonna be okay without the symptoms.
Right.
I think that's sort of, and that idea is sort of entrenched, I think, in OCD. As a child, I always thought that I had to do certain things in order for the Mets to win a baseball game.
Right, and you had nothing else to compare it to.
And I had nothing else to compare it to.
Yeah, I remember when I was 17, my 18-year-old cat died, and it really had an impact on me, because it occurred to me that there wasn't incontrovertible proof that the sky was blue without this cat. I was just kind of relying on faith there.
Yeah.
Yeah. So if you don't have anything to compare it to, that does make a difference. Yeah.
Mm-hmm.
I was researching a little bit, kind of thinking about things that we could discuss specific to the OCD community. And one thing that came up from the very limited studies I could find was that people who have OCD later in life tend to have later onset. And I was wondering if you had any thoughts as to, why there would be a correlation between, many times people develop onset in childhood. If you're male, it's usually around age 8 or so. If you're female, it's like 10 or 11. And but some people develop it later in life. They didn't have it, and then suddenly in their 30s they have it. What is it about having it when you're older, that do you think it has to do with just the way the studies are done, or the way it's reported, or could there be any other reason?
So you're saying late onset of OCD occurs later in.
So if you're studying people with OCD who are geriatric, more of them will have reported developing the OCD symptoms later in life, as opposed to not in childhood. I mean, any thoughts on that? I'm not supposing.
Well, there's a few things that could go into that, right?
Yeah.
There's a few things that could go into that. The people who develop OCD earlier in life and have been successfully in treatment.
Right, they might have been treated before.
So you're eliminating a big chunk of your interesting population with people who have been successfully treated or have overcome it in their own ways. Then you've got the possibility that what you're actually identifying is a early manifestation of another psychiatric or medical syndrome, right? So you cross-sectionally, you may find somebody who's developed OCD, but actually what they have is a late onset, late life depression, which often looks very different than the depression that would occur in somebody who was younger or in midlife, and would often be associated with ruminations on ideas of inappropriate guilt, somatic loss, etc. People with early onset Alzheimer's disease might also, if they were predisposed to such a thing, as they become more worried about not being able to remember where their keys are or something else, that could manifest and sort of as OCD initially.
Yeah.
There are late onset psychotic disorders that also could present this way. So it's hard to
with
know.
obsessions. Yeah.
Right. A lot of diagnoses in geriatric psychiatry actually need to be refined continuously over the subsequent lifespan, because sometimes you're surprised as to where it really goes. Somebody who initially seems psychotic could actually have a progressive dementia,
Right.
And the memory problems aren't prominent initially.
Do you ever encounter people who do not have significant memory impairment, but are afraid that they do? And they sort of have an obsession with their memory, and they're checking to see if they remember things, and they're worried about getting dementia, but it's actually just their OCD telling them that they're getting dementia.
That's something that actually, you know, as is true of many anxiety disorders, exists on a easily identified spectrum, right? There are a lot of people who started probably age 40 wondering whether or not they're having trouble with their memory and if they're forgetting, especially if they've been the caregiver of an affected family member.
So they have that point of context. I don't want to become like that.
I don't want, right. And then if you analyze the number of things that you forget, you're going to come up with a long list. And people typically are losing their keys or don't know where their wallet is at any given point. But if you've been the caregiver to a person who's affected with Alzheimer's disease, that can take on special significance for you, and it's easy to focus on that. And of course, the more you focus on that, the more it becomes a problem, and then that can snowball.
Yeah, the more you are testing your memory or asking yourself if you remember things, the more you're sending that signal to your brain that you're not sure, that you're not confident, and so it just leads to more questions.
Yeah.
So another thing that comes up in OCD work, sometimes we call it existential OCD, which is a kind of obsessive concern with either the meaning of life or what happens when we die, or how can I cope with the uncertainty of knowing that, yes, I will die one day, but I don't know how, and I don't know what's going to happen next. And spending a lot of time either researching this or just ruminating over it, or avoiding things that might trigger thoughts about it. And I would imagine a discussion with somebody with this existential obsession who's 44 is going to be a different discussion than someone who's 114. Right? You mentioned working with people who are, can get quite up there.
Mm-hmm.
I'm not really sure what I'm asking here, other than are conversations about death different when working with a geriatric population? Conversations about the fear and the uncertainty about death?
Basically, no. Basically, again, death is associated with age, and that's how aging stops, right? Aging stops with death. That's our ultimate path. There certainly are a lot of dying younger people. I worked for a short time in a cancer clinic, and they would consult me about patients who were at the end of their life who became very fixated on it, which becomes an urgent problem, really. It's probably some of the most urgent problems I've seen, because patients who are actively dying need to do a lot of, I'm not saying actively dying within minutes, but who have a life expectancy measured in months. There's a lot of work associated with dying, and patients need to get better in order to do that work. Otherwise, it's associated with additional feelings of inadequacy and guilt. We all walk around with a certain denial of our mortality. That's degree to which that's true probably doesn't change all that much with aging. As far as my experience goes, there are a lot of older people who refuse to face those issues, and there are people who are fixated at that from a much earlier point in their life.
Right. So there's not a huge difference between something that's unlikely to happen anytime soon versus somebody where, it's not unlikely that it'll happen within the next year if you're in your hundreds.
Oh, well, if you look at it from like what people are complaining about, there's not a lot of difference. If you look at the work that you need to do with somebody who is very old versus somebody who's very, who is much younger, the work that you do with them is different.
Yeah.
But it's not fundamentally different. You're still looking at having the person focus on issues of what their priorities are, what they want to get done.
And acceptance, I would assume.
And acceptance, yes.
So what about people who, one of the things that happens when you get around retirement, and I think for a lot of people with COVID also, this is either forced people into retirement or caused them to live a retirement-like lifestyle sooner than they had planned. The sudden isolation, the sudden separation from their social network. I guess
Loss
before
of identity, really, too, right? There's a huge loss of identity.
I mean, this seems like a petri dish for all kinds of psychiatric manifestations to show up, right?
Oh, it absolutely is. Unfortunately, what we think about all through our working age is how wonderful it will be to be retired. And people typically don't give enough thought to preparing themselves for the full meaning of retirement. For the overwhelming majority of people who have had a productive life, the idea of, sitting on a porch looking at a lake all day actually wears thin after a certain period of time.
Yeah.
And unless you've got some other plan, the days can be long, and you can have the sense that your life is actually sort of slipping through your fingers. It can be a time of, for all the reasons that you just noted. People at work have social contact, they have long-term relationships often. They have purpose, they have meaning, they have, literally a job. And without those things, that is a series of huge losses. And it needs to be filled on day one with a new plan.
Do you prepare people for this when you meet people say, I'm about to retire and I don't, I figure I'm just going to sit on the porch and I don't have much play. Do you try to intervene there and say, you really need to make sure you have some structure and, is that part of the work that you do?
Yeah, certainly any outpatient that I'm treating who's approaching or considering retirement, whether they're, under 65 or over 65, needs to take that transition extraordinarily seriously. We give a lot of counseling to people about getting married and preparing them for the workforce, but we don't really, I do, but there's not a lot of thought or not enough thought to preparing people for retirement.
Yeah. Well, think with all those losses, also just the quiet of it all, if you're predisposed to being an obsessive thinker, being a big ruminator, I would think that would be really hard on one's OCD as well.
Well, yeah, and I think that's why you're seeing a lot of this onset of OCD in older people, right? Because the OCD to some degree can be kept in check with somebody who has a lot of important other things to do. I'm not talking about the most severe cases, but people who are given to rumination, if you give them something else to do and you provide them social supports and they have some sort of meaning, and they're not left with their thoughts all day, tend to do much better than somebody who's just left in a space to focus on their own thoughts.
I've found with a few of my older clients, and it might just be a coincidence or a sample size of 3 here, so bear with me, but I found with a few of them that there's, in retirement, there's a lot of reflection on, did I do a good job with my life? Was I a good parent, a good grandparent? Was I righteous? Was I moral? Or also so I see a fair amount of moral scrupulosity and religious scrupulosity as well, concern about, have I sinned or did I do the right thing? And I wonder, is this just, it's a kind of OCD that shows up, it's not unusual in OCD and it's just coincidental that this is an older person, or if there is something about that disconnection, that isolation that just giving them more time to spend thinking about it when they would otherwise be busy with work or family is kind of bringing that OCD to the forefront.
Yeah, I think it's the latter for all the reasons I was saying.
Yeah. The study that I looked at that was talking about geriatric OCD being associated with later onset of the disorder also said that the most common OCD symptoms in geriatric OCD were contamination-based or sin-based. And usually when they say sin-based, it usually also includes the kind of moral sin. I just thought that was interesting that it was those two symptoms. And I definitely also noticed since COVID, some of my older clients really struggling with the contamination side of COVID. How do I handle my mask? How do, it's new information. It's sort of like, I don't want to have to learn this new world now. I've spent, 60, 70 years trying to figure out how the world works. And now you're changing the rules on me. And there's some kind of real resistance there. Have you noticed this as well?
Certainly. I mean, people, again, getting the idea of these, behaviors being literally entrenched. It's harder for people to believe that they need to change their lives that radically. And the changes that we're asking of the elderly because of the, obvious risks to the elderly, or, we're asking a lot of them in terms of being isolated. It's easier for me to be socially distant and isolated because I have an opportunity to talk to you over Zoom. I have an opportunity to work in a hospital with other people.
And you're comfortable with the technology already. You're not having to learn it for the first time.
Yes,
right?
Yeah, right. I'm used to relating people I'm used to relating to people over a computer, which somebody even a little bit older than I am wouldn't be able to wrap their mind around.
Yeah, and dealing with the uncertainty too of do I have the right mask, or am I using hand sanitizer at the right time, or am I following the CDC guidelines in the right way? It's a lot of questions at once for anybody, but I would think for someone in the geriatric population, it's a big ask. And I can see how it would lead to obsessive rumination and avoidance and compulsions, just needing to be sure you're doing it right, because it's like a big test every day.
Yeah, and over the last year, it's been hard to know that you're doing it right. Whether you are actually following the instructions correctly. You may have there's a lot of things that we found out. Don't do what we told you to do, and so it's very difficult to know whether or not you're doing the right thing. And the consequences are just so much more severe. Somebody who's 20 years old who contracts COVID is at an enormously different risk group than somebody who's 90. And there's a need to get it right.
Right. It's not like if you get it wrong, you could just cope with the consequences, like most situations. The consequences.
Yeah, no, it's easier to walk on a rope that's on the floor than it is walk on a rope that's 50 feet in the air.
Yeah, that's true. That's true. With a vat of crocodiles under it. Yeah. One last question. Because I get to ask this a lot by clients. They want to know, is it going to get worse as I get older? And they want to know, especially clients who have fear of losing control. I work with a lot of people who have unwanted, intrusive, violent thoughts. These are peaceful people who just have these ego dystonic thoughts. What if I were to just push someone in front of a car? What's to stop me from just picking this up and cutting myself? And they worry about these things, and they avoid, and they try to get certainty that they won't act out. And then they hear about dementia and delirium and things where people kind of lose control of their faculties, and they really worry, what if that happens to me? And I guess there's two parts to this question. One is, are there conditions where people lose control, and how do you handle that? And then the other question, maybe the easier question, is just, is there any reason to think that if somebody is well treated for OCD throughout their life, that just getting older would necessarily make it worse?
There's nothing inherent in OCD that would make the symptoms worse with age. I think it's important to be mindful of the stresses that arise with aging, right? Because if somebody with adequately controlled OCD finds themselves in an overwhelmingly anxiety-provoking situation,
like
or
COVID.
like like COVID or any one of the range of things that can occur, right? As somebody transitions into later life, the things that you're losing control of.
And grief too. I mean, we haven't talked about this, but
Yeah,
losing.
there are a lot of losses associated with aging, right? We have a society that's based around being productive and working, or supporting the people who are working.
You were describing how there's no reason to think that OCD would get worse just because somebody got older, but getting older comes with specific stressors that are anxiety producing, that might cause OCD to get worse on its own. But that would be true. And there are other stations of life that have other kinds of stressors that could exacerbate anxiety. So it's really the life context that makes a bigger difference than just the number on your driver's license.
That's right.
Yeah, that's interesting. And the other part of my question was about the fear of loss of control. So a lot of my clients who worry about, when I'm older, what if I do something embarrassing, or what if I hurt somebody because something happens to my brain? Is there anything? We're not supposed to give reassurance to our clients as part of the OCD treatment, but I'm wondering if there's anything reassuring that you could give my clients that addresses that notion that getting older necessarily involves losing control, or losing control necessarily involves something terrible happening.
Yeah, and it comes under that broad category of I would never want to be a burden to my loved ones. And I think that's one of the great fears that people have as they approach late life. Right? Alzheimer's disease is a disease where the single greatest risk factor is age. And if we all lived long enough, we would actually probably all eventually develop Alzheimer's disease. And that's why we have so much more of it now than we used to, because people are living longer. There are a lot of modifiable factors that can decrease the risk of Alzheimer's disease: proper diet, regular exercise, sort of addressing stress. If somebody is facing the prospect of a very long life, they're also running the risk of Alzheimer's disease. And almost universally, people don't want to be a burden to their loved ones, and especially don't want to be the source of physical violence towards loved ones. And our view of people often doesn't. Our view as a society of people often doesn't take into account the basic dignity of all human beings. And I think that's one of the problems that I find with people who become concerned about who and what they will be much later in life, is they don't realize that regardless of what happens to us, we maintain our basic human dignity and our basic human worth.
That's a beautiful note to end on. I think that's a perfect button to the conversation. So Dr. Marino, thank you so much for your time and your expertise. And I hope the viewers got a lot out of this discussion.
Well, thank you very much as well. I very much enjoyed talking to you and thinking about these complex questions.